This talk is about sphingolipidosis. Sphingolipidosis results from the accumulation of lipids derived from the turnover of obsolete cell membranes. It will help you understand this video to have seen two other videos in this channel, sphingolipids and classification of lysosomal storage diseases. The talk on sphingolipids goes through the normal catabolic pathways of sphingolipids. It will get you acquainted with the basic components of sphingolipids and the steps involved in their catabolic pathways. The second video, classification of lysosomal storage disorders, places sphingolipidoses in the context of other lysosomal storage disorders. As you can see in this frame, sphingolipidoses are the consequence of lysosomal translational or activator errors leading to the accumulation of single and rather simple materials. The sphingolipidoses, here listed, are produced by deficient enzymes or activators, blocking the normal catabolic pathways of the different sphingolipids, which I will now name sphingomyelin, cerebrosides, sulfatides, globosides, and gangliosides. The diagnosis of sphingolipidosis is based on clinical suspicion, which relies on picking the right condition among the many conditions producing similar findings. At times, this clinical suspicion is supported by laboratory findings, such as a high plasma chetotriosidase activity, a biological marker of macrophage activation, a telling sign of patients with Gaucher disease, Niemann-Pick A and B, and GM1 gangliosidosis. At other times, the clinical suspicion is supported by radiological findings. Either way, the diagnosis is confirmed by genetic testing. So, our approach during this talk will be to name the mutated gene, name the sphingolipid involved, name the deficient enzyme or activator, and indicate its place in the catabolic pathway. Then I will indicate the anatomical systems responsible for the salient clinical manifestations of each condition, keeping in mind that with global brain involvement, time is often the arbiter of the neurological manifestations. By this I mean that a disease that primarily involves the central nervous system gray matter, let's say the cerebral cortex, will manifest as global developmental delay in an infant, as seizures in a child, and produce psychiatric symptoms in an adult. And finally, I will highlight the finding or findings that makes a given condition more likely than any other condition capable of producing relatively similar symptomatology, and at times use footnotes to bring up new points or clarify old ones. So, let's start going over this 10 alphabetically arranged lysosomal storage diseases involving sphingolipidosis. First condition, Fabry disease, also called Anderson-Fabry disease. Fabry disease is an X-linked condition resulting from a mutation in the GLA gene. The defective enzyme in Fabry disease involves the globosides and the cerebrosides pathways. The deficient enzyme is alpha-galactosidase A. Thus, the conversion of GB3 or globotriaosylceramide to lactosylceramide does not occur or is limited. Nor does the conversion of digalactosylceramide to galactosylceramide occurs normally. This enzyme defect at two different sites leads to the accumulation of globotriaosylceramide and its derivative, lyso-GB3. This derivative is formed by the loss of fatty acid, the third substance that accumulates in Fabry disease, although to a lesser degree is D-galactoceramide, and the fourth one is its lyso derivative, also called D-galactosphingosine. The neurological manifestations are consistent with white CNS pathology, resulting primarily from vessels involvement. This figure corresponds to an intracranial vessel. In normal situations, the endothelial cells offer a seal boundary between the blood and the vessel wall, but not in patients with Fabry disease. In Fabry disease, damage to the endothelial cell renders it ineffective as a barrier, leading to a mechanically weak wall. The effect of this disruption, here represented in a brain vessel, also takes place in vessels outside the brain, in the conjunctiva. Notice the tortuous trajectories of the subconjunctival vessels, and using the ophthalmoscope, in the retina. This is the retina of a patient with Fabry disease. The vessel's trajectories are tortuous. This is especially noticeable when compared to the trajectory of normal retinal vessels. Brain MRI and MRA are also very revealing in patients with Fabry disease. Here you can see the image of the cerebral posterior circulation vasculature in a patient with Fabry and a normal patient. The vertebral arteries come together, forming a relatively straight basilar artery that splits, forming the posterior cerebral arteries. Here in a patient with Fabry, you see the splitting, but the basilar artery and the vertebral arteries are elongated and have a very tortuous trajectory. In this image, you can see elongation and dilatation of the left and the right middle cerebral arteries and the basilar artery. This pathology is often referred to as dolichoctasia. Other brain abnormalities seen in Fabry disease are stroke, bilateral pulvinar pathology, and white matter pathology. White matter pathology is the most common, but the least specific of the just mentioned radiographic findings. In addition to the predominance of white matter CNS pathology, as we just saw. Peripheral nerve pathology, although less often, may also occur and produce distal peripheral neuropathy manifested by burning feet and pins and needles in the hands. We may also encounter sensory neural hearing loss and a gamut of GI symptoms, abdominal pain, nausea, constipation, bloating, and especially diarrhea. They result from involvement of the submucosal and the myenteric GI plexi. In Fabry disease, clinical manifestations are not confined to the nervous system. General findings are the rule, such as cornea verticillata, arrhythmia, proteinuria, renal failure, and hypohidrosis, due to neuropathy, vascular insufficiency, and obstruction, resulting in loss of temperature regulation. The hallmark of Fabry disease is the presence of angiokeratoma. This figure from an 1898 article titled A Case of Angiokeratoma, written by Dr. Anderson, illustrates an oblique section of an angiokeratoma. In it, we can see the stratum corneum, the stratum malpighi, a dermal papilla, and a superficial and deep ectatic vessels. Currently using better microscopes, staining methods, and photography, we can more clearly see ectatic vessels in the dermis and the epidermis, acanthoses, and hyperkeratosis. The distribution of the skin lesions were illustrated by Anderson. They occur just about anywhere, sometimes being very prominent in the eyelids, or more frequently in the lower back. But occasionally, early in the course of the disease, they are only present around the umbilicus. So, look at the umbilicus when considering the diagnosis of Fabry disease. Footnote: despite being an X-linked disorder, the male-female ratio is about 50-50. An unusual feature of Fabry's disease is the presence of clinical signs and symptoms in the majority of heterozygous female carriers, despite normal or near-normal alpha-galactosidase A activity levels. Manifestations are usually less severe and of later onset than in affected males. The diagnosis is made by genetic studies. End footnote. The second disorder is Farber lipogranulomatosis. Farber lipogranulomatosis is an umbrella term for 7 conditions that have in common the presence of low ceramidase activity. Neurological manifestations are present in types 5, 6, and 7. Farber lipogranulomatosis type 5 is an autosomal recessive lysosomal storage disorder. It is caused by mutations in the ACER-H1 gene, located on chromosome 8. Theoretically, it involves all the sphingolipid pathways because it affects the end step in their degradation. The low ceramidase activity is due to a low level of ceramidase. This enzyme deficiency, as we just mentioned and as is shown in this frame, is at the end of sphingolipid pathways. The result of this deficiency is that the splitting of ceramide into sphingosine and fatty acid does not occur or is limited in this condition. The major accumulated substance is ceramide. Fabry disease type 5 usually presents between 1 and 2.5 years of age, with signs of central white matter pathology involving the brain, the spine, or both. Systemic signs of lipogranulomatosis are always present, but may be mild. I will now present an illustrative case. This photo was taken at 12 months of age. In it, you can see the swollen joints and subcutaneous nodules. At 20 months, 2 months after hematopoietic stem cell transplantation, you can see that the nodules are gone. At 30 months of age, horizontal pendular nystagmus and truncal titubations appeared. MRI of the brain was normal. At 40 months of age, ataxia was noted. MRI showed cerebellar atrophy, and an EMG done at about the same time was consistent with lower motor neuron pathology. Footnote: an ASAH1 gene mutation is associated with a syndrome that combines spinal muscular atrophy and progressive myoclonic epilepsy, and minimal, if any, evidence of subcutaneous or periarticular lipogranulomatosis. End footnote. Now let's say a few words about type 6. Farber lipogranulomatosis type 6 is often referred to as combined Farber and Sandoff disease variant. It is due to concomitant mutation of the ASAH1 and HexB genes. The latter is the gene involved in Sandoff disease, a condition we will address in a few minutes. So, for now, let's just say about this very rare disorder that it presents in a similar fashion as Farber lipogranulomatosis type 5, but accompanied by hepatomegaly, and it has an earlier age of presentation. Next, we will talk about Farber lipogranulomatosis type 7. Farber lipogranulomatosis type 7, also called prosopocin deficiency, is due to multiple sphingolipid activator protein deficiencies. It is due to PSAP gene mutations. The PSAP gene is on chromosome 10. Farber lipogranulomatosis type 7 is inherited in an autosomal recessive fashion. Standing on the principle we mentioned when discussing Farber lipogranulomatosis type 5, and considering that type 7 combines decreased ceramidase activity with reduced activity of other sphingolipid enzymes. We can say that Faber lipogranulomatosis type 7 involves all the sphingolipid pathways. It is important to stress that the decreased activities of these enzymes occur in the presence of high levels of the enzymes. This is so because in type 7, it is the activator proteins that do not work and not a primary enzyme issue. In this condition, the mutated prosapacin causes the deficiency of three sapacins, named B, C, and D. These abnormal activator proteins lead to low enzymatic activity of glucocerebrosidase, galactose-arabrosidase, and ceramidase, and therefore the accumulation of ceramide, glucoceramide, globoside, triosylceramide, and galactocerebroside. Footnote: there is no solid, rational explanation for low sapacin B activity in this condition, only hampering alpha-galactosidase A activity, while sparing the activity of GM1, ganglioside beta-galactosidase, sialidase, lactosyl ceramide beta-galactosidase, and aerosulfatase A, since sapacin B is an activator for all of them. End of footnote. Clinical manifestation and MRI findings point to a prevalence of gray CNS matter. Pathology involving the brain. General manifestations are also present. I will now present an illustrative case. These are photographs of two patients with prosapacin deficiency. Their clinical manifestations were hepatosplenomegaly, microcephaly, cataracts, optic nerve atrophy, hypotonia, poor or no consciousness, and seizures. An MRI at 5 months of age in the first case, and at 2 months of age in the second case, showed cortical dysplasia and small strokes pointed by the black arrows. Footnote: the labeling of prosapacin deficiency as Faber lipogranulomatosis 7 is currently under scrutiny. Some articles only list 6 types of Faber lipogranulomatosis and treat prosapacin deficiency as a separate entity. End of footnote. The hallmarks of Faber disease are the presence of painful and swollen joints, subcutaneous nodules, and hoarseness due to vocal cord nodules. The next sphingolipidosis we will address is Gaucher disease. Gaucher disease is an autosomal recessive condition due to a mutation in the GBA1 gene located in chromosome 1. Atypical Gaucher disease is also an autosomal recessive disorder caused by a specific mutation in the PSA gene located on chromosome 10 that only produces sapacin C deficiency. These conditions involve the common catabolic pathway of gangliosides and globosides. The deficient enzyme in Gaucher disease is glucosylceramide beta-glucosidase, also known as glycosylceramidase beta-glucosidase, or sapacin C in atypical Gaucher disease. A block at this site leads to the accumulation of glucosylceramide and its derivative, glucosylsphingosine. Most patients with Gaucher disease or atypical Gaucher disease, conditions that from this point on we will address together, and indicate so by adding a plus sign to Gaucher disease, do not have neurological manifestations. Only 10% do. Neurogenic symptoms present either acutely in type 2 or chronically in type 3. Those with type 2 show signs of white matter disease, mainly affecting the brain, signs of gray CNS matter disease, and general findings. Type 2 salient neurological manifestations may present during the first months of life with hepatosplenomegaly and opisthotonus, or present later with signs of brainstem dysfunction, such as swallowing difficulties, hypernasal voice, and strabismus. MRI of the brain in the acute form may show evidence of brainstem and cortical atrophy and thalamic abnormality. Maximal in the pulvinar nucleus may be present. Gaucher disease type 3 manifestations usually start after 6 years of age and have a chronic course. Neurological manifestations reflect gray matter pathology affecting the brain and especially the brainstem, often producing supranuclear ophthalmoplegia. IQ is often normal. Cerebral pathology in older patients may manifest as psychiatric symptoms. General manifestation ranges from minimal to severe and have a wide range of manifestations, including growth retardation and corneal clouding. These are the photographs of a 10-year-old with Gaucher type 3. Notice abdominal protrusion due to hepatosplenomegaly. Skeletal findings include short stature, abnormal posture, and widely distributed dysostosis. Some patients with Gaucher disease, usually type 3, have Erlenmeyer-Flask deformities. Notice the gradual progressive widening of the distal femur. The hallmarks of Gaucher disease or atypical Gaucher disease are the presence of hepatomegaly, very high plasma chitotriosidase activity, bone marrow aspiration, and subsequent microscopic examination will show characteristic macrophages. They're called crumpled tissue paper-like cells because of the typical appearance of the cytoplasm, as you see here, and in this new specimen. In normal individuals, monocytes normally last up to a few days before dying. Once dead, they are then taken by macrophages and digested. Post-digestion, normal macrophages have a smooth cytoplasm. In a patient with Gaucher disease, monocytes last a little shorter due to splenomegaly. Once dead, they are then taken up by macrophage. But the macrophage in Gaucher disease, or atypical Gaucher disease, is unable to digest glucosylceramide properly, and glucosylceramide accumulates, forming fibrillary aggregates. These long, thin tubular aggregates give the cytoplasm its striated, wrinkled paper look. Footnote: this figure correlates the size of the rectangles with the frequency of the different neurological findings in adult patients with enzymatic or activator deficient Gaucher disease types 1, 2, and 3. As you see, Parkinsonism is the most often encountered neurological manifestation. Yet just about anything can happen. End of footnote. The next sphingolipidosis we will address is GM1 gangliosidosis. GM1 gangliosidosis is an autosomal recessive condition. It is due to a mutation in the GLB1 gene located on chromosome 3. GM1 gangliosidosis involves the catabolism of gangliosides and, to a lesser extent, globosides. The deficient enzyme is GM1 beta-galactosidase. This enzyme is essential for the conversion of GM1 to GM2. Its absence or reduced amount leads to accumulation of GM1 ganglioside and its Asia-low derivative GA1. GM1 ganglioside beta-galactosidase probably participates, but it is not essential in the conversion of lactosylceramide to glucosylceramide. Thus, lactosylceramide is usually not increased to a significant degree in patients with GM1 gangliosidosis. But notice that in addition to detaching galactose from GM1 and from lactosylceramides, it also detaches galactose from keratan. Failure to do so leads to the accumulation of keratan and dysostosis multiplex in patients with GM1 gangliosidosis. And in addition, GM1 beta-galactosidase detaches galactose from nitrogen-linked and oxygen-linked glycans. Failure to do so leads to oligosaccharides being excreted in the urine. Clinical manifestations are primarily those of gray matter, CNS disease, involving the brain and the spine. The cerebellum appears especially vulnerable in older patients. White matter is also affected in the same structures. General manifestations are prominent. Based on the age at the onset of symptoms, GM1 gangliosidosis is divided into 3 types. Dysmorphic faces are present in the infantile form. In the late infantile form, we may find patients with mild anomalies of the ears, a prominent philtrum, and gingival hypertrophy. Cherry red spot is only present in about half of type I cases and rarely in the other types. Brain involvement is maximal in type 1, but also occurs in type 2, more so in the late infantile than in the juvenile form. In the chronic or adult type, CNS manifestations mainly present as cerebellar and extrapyramidal findings. Hepatosplenomegaly is usually encountered in the infantile form and less so in older patients. Heart disease, mainly hypertrophic cardiomyopathy, and, less likely, conduction defect occurs in all types. Type 3, GM1 gangliosidosis is more common in Japan. The hallmarks of the infantile form are the presence of dysmorphic facial features, hypotonia, hepatomegaly, and a cherry red spot. GM1 types 2 and 3 do not have specific features that allow them to be spotted among the many conditions producing all sorts of neurological deficits. They confront the physician with a most puzzling situation: the common finding produced by a rare disease. Gingival hyperplasia, in the right setting, may be a clue for type 2, or late infantile GM1 gangliosidosis. Family history suggestive of an autosomal recessive condition may be a clue. Footnote: looking at the elements inside the green rectangle, now enlarged, it is hard to understand why neither Sepacin B nor GM2 activator protein deficiencies do not produce GM1 gangliosidosis, but I have not been able to find any such case report. Hence, I surmise that these activators help but are not essential for the conversion of GM1 to GM2. End of footnote. The next sphingolipidosis we will address is GM2 gangliosidosis, B variant, or Tay-Sachs disease. This condition is more common among the Ashkenazi Jewish population. The use of the term B variant for this condition deserves a comprehensive explanation. I will attempt to do so using this table. A normal person has hexosaminidase A and B activity in plasma, as illustrated by the two humps, because both hexosaminidase subunits, alpha and beta, are produced. A person with GM2 gangliosidosis, B variant, or Tay-Sachs disease has a mutated hexagene, which is at chromosome 15. Such a person will not produce hexosaminidase alpha, which I have colored red. Hence, there will be no hump in the area where normal people have the hexosaminidase A hump. The hexosaminidase B hump will be present because it only has beta subunits. Hence, the term B variant is used. Tay-Sachs disease exclusively involves the ganglioside pathway. The enzyme involved is, as we know, beta-hexosaminidase A, leading to the accumulation of GM2 ganglioside, GA2 ganglioside, and lysogm2 ganglioside. Clinical manifestations are primarily those of brain gray matter involvement, but spinal cord motor neurons may be affected. Tay-Sachs disease manifestations are solely due to GM2 accumulation in neurons. No general manifestations are present. GM2, variant B, infantile type, start during the first 6 months of life. Neurological manifestations progress rapidly. Blindness and auditory triggered startles are common. Short-lived macrocephaly may be present in the late infantile type. The subacute juvenile form starts in childhood or adolescence. Neurological manifestations advance at a slower pace and survive longer. The adult type may present with progressive lower extremity weakness, psychiatric symptoms of depression and psychosis, or spinocerebellar symptoms such as ataxia and dysarthria. The hallmarks of this condition in the right setting are: in the infantile form, a head size that jumps up percentiles becomes macrocephalic, but shortly after ceases to grow, thus starts dropping percentile, absence of dysmorphism, and cherry red spot. Ashkenazi Jewish heritage and a family history suggesting an autosomal recessive condition make Tay-Sachs more likely. The juvenile or adult type does not have specific features that allow them to be spotted. Ashkenazi Jewish heritage and a family history suggesting an autosomal recessive condition make Tay-Sachs more likely. The next Sphingolipidoses we will address is GM2 gangliosidosis variant 0, also called Sandhoff disease. I will take a few seconds to explain why it was labeled variant 0. I hope you recall this table and the comments we made about the normal control. If you do not, listen to the previous section. In patients with Sandhoff, the mutation is in the HexB gene located on chromosome 5. Patients with Sandhoff do not produce hexosaminidase A or B because they are unable to produce the beta subunits, which is a constituent of hexosaminidase A and B. Hence, the hexosaminidase pattern shows 0 humps. Thus, the term 0 variant. Sandhoff involved the ganglioside and globoside pathways. The enzymes involved are beta-hexosaminidase A and B, blocking the conversion of globotetraosylceramide to globotriaosylceramide and the conversion of GM2 to GM3. As a consequence of these blocks, GM2, lysogm2, and globotetraosylceramide accumulates. Neurological manifestations are those of gray matter central nervous system involvement, affecting the brain and spine, but unlike in Tay-Sachs disease, general system manifestations are present due to visceral storage of globotetraosylceramide. So, in patients with the infantile type of Sandhoff disease, in addition to the neurological manifestations we encounter in patients with infantile Tay-Sachs disease, including the cherry red spot, we find significant hepatosplenomegaly, skeletal abnormalities, and kidney problems. The juvenile type may present as a lower motor neuron disease. In those patients, muscle biopsy show group atrophy and spared myelinated fibers in an intramuscular nerve twig. The adult type may also present as a lower motor neuron disease with significant proximal muscle weakness. The hallmarks of this condition in infants and children are neurological findings consistent with gray matter central nervous system damage, splenohepatomegaly, skeletal dysplasia, and dysmorphism. A family history consistent with an autosomal recessive disorder may help. In the adult type, the hallmarks are the onset of lower motor neuron disease in conjunction with splenohepatomegaly. The next Sphingolipidosis we will address is GM2 gangliosidosis variant AB, or GM2 activator deficiency. I have gone back to the original table to tell you about GM2 activator protein deficiency. It is due to a mutation in the GM2A gene located on chromosome 5, but not in the same region as in the case of Sandhoff disease. GM2 activator protein deficiency is inherited as an autosomal recessive condition. A patient with a mutated GM2 activator protein will produce hexoaminidase alpha and beta. Hence, the hexosaminidase A and B bumps will be present. That is the reason it is called the AB variant. Variant A, B involved the ganglioside pathway. The missing actor is the GM2 activator protein, thus blocking the conversion of GM2 ganglioside to GM3 and the accumulation of GM2, GA2 ganglioside, and lyso-GM2 ganglioside. The hallmarks of this condition in infants and children are neurological findings consistent with gray matter central nervous system damage, similar to those in Tay-Sachs disease. A family history consistent with an autosomal recessive disorder may help. To my knowledge, no adult with this condition has been reported. The next Sphingolipidosis we will address is globoid cell leukodystrophy. It includes Krabbe disease, an atypical Krabbe disease. Krabbe disease is an autosomal recessive disorder caused by a mutation in the GALC gene located on chromosome 14. Atypical Krabbe disease is also an autosomal recessive disorder caused by a specific mutation in the PSAP gene located on chromosome 10 that exclusively fails to produce sapacin A. These conditions involve the cerebroside pathway. The affected enzyme in Krabbe disease is the galactoceramide beta-galactosidase, also called beta-galactocerebrosidase. In a typical Krabbe, as we just mentioned, the issue is activator saposin A deficiency. There is a failure of galactosylceramide to become ceramide, leading to the accumulation of galactocerebroside in cerebral macrophages, but not in any other CNS cell. An accumulation of cytosine formed by the removal of fatty acid by the action of ceramidase that accumulates in white matter-producing cells, oligodendrocyte and Schwann cells. Krabbe disease and atypical Krabbe disease involve the white matter in the CNS and in the peripheral nervous system. In the classic form, which can be produced by the beta-galactocerebrosidase or sapacin A deficiency, the patient is normal at birth, but soon after, irritability appears. One of my old professors once told me that the first signs of Krabbe disease is a crabby baby before the age of infantile colic. This is shortly followed by spasticity that gives way to hypotonia as the disease progresses. There is a lack of developmental progression, and if milestones are achieved, they are soon lost in most cases. Late onset forms are characterized by the appearance of signs of white matter brain pathology and spinal pathology, followed by signs of peripheral neuropathy. Now, let's look at histology. Galactocerebroside accumulates in cerebral macrophages that fuse to form multinucleated cells. Notice that the individual macrophage has its nucleus pushed to the side by the cytoplasm, thus resembling a balloon. Hence the term globoid encephalopathy was used for this condition. It is important to mention that the accumulation of galactocerebroside is minimal because it quickly becomes cytosine. Cytosine, as we previously mentioned, also accumulates in oligodendrocytes and Schwann cells, producing demyelination and secondary axonal damage in the CNS and PNS. This is the brain of a 15-month-old with Krabbe disease. In it, we can see tissue undergoing different degrees of involvement. There is mild damage to the white matter of the corona radiata, bilateral, symmetrical cavities in the posterior limb of the internal capsules, and in the corpus callosum. U fibers are spared. The different degree of pathology is demonstrated in histological specimens. In this figure, we can see small globoid cells located in clusters around vessels with relatively well-preserved white matter. In this new specimen, you see numerous globoid cells with several nuclei in a sea of damaged white matter. And in this specimen, you see few multinucleated globoid cells with abundant nuclei in a sea of completely disintegrated white matter. The progression of Krabbe disease is documented by MRI. Initially, we find thickened optic nerves due to the accumulation of globoid cells. Later, we see shrinking white matter. The U fibers are not affected. The hallmarks of globoid cell leukodystrophy are early onset irritability in the first few weeks of life, lack or delayed milestone acquisition, followed by spasticity and later hypotonicity. The next sphingolipidosis we will address is metachromatic leukodystrophy. Metachromatic leukodystrophy can be produced by three genetic abnormalities. Two of them we are going to discuss now: metachromatic leukodystrophy and sapacin B deficient MLD. The third one we will discuss as a footnote. Metachromatic leukodystrophy is an autosomal recessive disease due to a mutation in the ARS-A gene located on chromosome 22. Sapacin B deficient metachromatic leukodystrophy is also an autosomal recessive disorder caused by a specific mutation in the PSAP located on chromosome 10 that fails to produce a sapacin B, which selectively targets sulfatides. It would make sense to use the term atypical MLD, as we did when dealing with the prior sphingolipidoses due to activator deficiencies. But the term atypical MLD is already used to denote MLD with atypical clinical manifestations. Both conditions involve the sulfatides pathway. The deficient enzyme in MLD is aryl sulfatase A. The deficient substance in sapacin B, deficient MLD, as we have already mentioned, is sulfatide-specific sapacin B. They block the conversion of cerebroside sulfate to galactosylceramide, leading to the accumulation of cerebroside sulfate. Metachromatic leukodystrophy involves the white matter in the CNS, affecting the brain and, less often, the spine. This MRI shows significant white matter disease with sparing of the U fibers. As indicated, the spine may also be affected. In addition to the central nervous system, white matter, and just as often, the peripheral nervous system shows signs of demyelination. Microscopic examination of the affected tissue displays a very characteristic finding, which led to the naming of this disease. In this frame, using crystal violet stain, you can see a normal cerebellum with the white matter staining light violet. Crystal violet staining tissue violet is referred to as orthochromic. This specimen corresponds to cerebellar tissue of a patient with metachromatic leukodystrophy. As you can see, the white matter is staining a brilliant brownish color. The characteristic of a tissue staining a color different from the expected is referred to as metachromia. Hence, the term metachromatic leukodystrophy is used for this condition. Here, toluidine blue was used to stain nerve tissue. The normal nerve tissue stains blue. The nerves of patients with metachromatic leukodystrophy stain red and show clumps of material. Based on onset age, we have a late infantile form, with onset between 1 and 3 years. That presents with rapidly progressive signs of CNS and PNS demyelination. A juvenile form, with onset between 3 and 16 years of age, has a slower progression, and an adult form that may present with psychiatric symptoms of depression and psychosis, and signs of demyelinating neuropathy before seizures and dementia appears. It is essential to emphasize that not all patients with low sulfatase activity exhibit symptoms. In addition to nervous system involvement, accumulation of sulfatides outside the nervous system produces significant symptomatology, most notably those produced by gallbladder involvement. Here you see a gallbladder ultrasound and a surgical specimen. Gallbladder involvement is characterized by wall thickening, perichole cystic fluid, polyposis and papillomatosis, and neoplasms. Sulfates are also excreted in the urine in patients with MLD. A few drops in special paper produce a very peculiar spot. The hallmarks of low sulfatase activity due to enzymatic or activator deficiencies are the association of white matter, CNS findings, demyelinating neuropathy, and gallbladder involvement. Footnote: now, I will address the third condition associated with low sulfatase activity. Multiple sulfatase deficiency is often called metachromatic leukodystrophy variant 0. This autosomal recessive condition is due to a mutation in the SUMF1 gene, located on chromosome 3. The SUMF1 gene produces the formoglycine, generating enzyme. This enzyme's activity is necessary for the activation of all sulfatases, including aryl sulfatase A. Patients with multiple sulfatase deficiency usually present in the neonatal period or shortly after with coarse face, high-arched, thick eyebrows, bulbous nasal tip, micrognathia, posteriorly rotated ears with attached lobes, and ichthyosis. Skeletal abnormalities consistent with mucopolysaccharidosis are present in the hand and distal forearm, at the base of the brain, lumbar spine, and broad ribs. End of footnote. The last condition we will address is Niemann-Pick A and B and AB. They are autosomal recessive conditions. The gene mutations responsible for Niemann-Pick A and B and AB is SMPD1. Niemann-Pick disease type A tends to be more common in individuals of Ashkenazi Jewish ancestry. Niemann-Pick A and B and AB involve the sphingomyelin pathway. The deficient enzyme is sphingomyelinase. Thus, phosphorylcholine ceramide does not become ceramide, resulting in increased phosphorylcholine ceramide, colloquially referred to as sphingomyelin. Sphingomyelin accumulation produces central gray matter manifestations. The site most affected is the brain. White matter changes in the brain also occur. General findings are also prominent. These are photographs of patients with Niemann-Pick type A and type B. There is also, as you know, a type called AB. It is an intermittent type between A and B. These conditions have different timing. Younger patients usually have type A, older patients have type B, and those between them usually have type AB. The amount of sphingomyelinase activity present loosely correlated with the age of onset and course. CNS manifestations are prominent in type A. They are minimal to none in type B. CNS manifestations of the type A/B variant is between types A and B. They consist of developmental delay and hypotonia. Hepatosplenomegaly has the same profile as CNS manifestations. Interstitial pneumonia is more frequent in B than in A. These photographs are of a patient with Niemann-Pick type A. Notice failure to thrive and the large Mongolian spots. Cherry red spots are present in about 50% of the cases, even in some patients with no apparent neurological findings. This photograph of a child with type AB shows massive hepatosplenomegaly and failure to thrive. The chest X-ray shows interstitial pneumonia. Brain images in patients with Niemann-Pick type A may show diffuse thalamic and asymmetrical white matter pathologies, lissencephaly, and absence of the corpus callosum, bone marrow, aspirate, and subsequent microscopic examination shows characteristic cells with a foamy soap bubble appearance. The appearance of these macrophages is caused by the accumulated sphingomyelin and probably other sphingolipids that form globular aggregates. In the upper row of this frame, I am illustrating the normal process used to get rid of old monocytes, which I have shown you before, culminating in a smooth macrophage. In the bottom row, the macrophages, not having the means of disposing of sphingomyelin, produce a soap bubble cytoplasm. The telling signs of Niemann-Pick disease, A, B, and AB, is the combination of hepatosplenomegaly, failure to thrive, large Mongolian spots, cherry red spot, and Jewish heritage. Footnote: according to Dr. Ferreira, sapacin D deficiency produces Niemann-Pick disease. But current literature does not support this assertion, because although past literature listed sapacin D as an activator of sphingomyelinase, recent literature does not, as you will see in the next few frames. In 2001, a senior author listed SAPC and D as activators of sphingomyelinase activity. The same senior author did not mention these activators in 2006, nor in 2013, nor in 2023, nor have I found a case report of sapacin D deficiency Niemann-Pick disease. Thank you.